To all participants and viewers, a special thanks to the doctors who are presenting our cases this morning. The first case will be presented by Dr. Eduardo Paulino from INCA in Rio de Janeiro, Brazil. Our second case from Dr. Aknar Calabrish from Clínica AMO in Salvador, Brazil. And the third case we haven't had her join, but it's the first time we'd like to welcome Guatemala. And Dr. Anasaidi Albanese from Instituto Cancerologia Hospital in Guatemala will be presenting our third case if she joins us. She hasn't yet joined. And a special welcome, as I said, a special welcome to Guatemala if they join, because it's their first time today, and a special welcome and thanks to our panelists from MGH and around the US. So good morning, everybody. I'd just like to emphasize the usual housekeeping rule of keeping your mic muted, and I think everybody's doing that. Thank you very much, because that helps us. If you want to speak, you just turn your microphone on. And also a reminder that the PowerPoint cases in YouTube will be available archived after the meeting. And also at the end of the tumor board, which you like very much, somebody's got their microphone. Good morning. Could you move?
It's on. It's on. Yeah.
We just want to ask everybody, if you wouldn't mind, can you please take some photographs of yourselves and later on after the meeting of your hospital, your clinics, and with their permission of your patients receiving a big hug or getting chemotherapy or waiting in line for clinic. We would value any photographs taken with your iPhone. Please send them to Jessica after the meeting. And with that introduction, we'd like to get started. So I'd like to welcome Dr. Eduardo Paulino from Rio de Janeiro, and Eduardo is going to present our first case this morning. Eduardo, good morning. Go ahead when the slides are on. Come up, please.
Good morning, everybody. I'd like to thank again for this opportunity. And on behalf of my institution, I'm going to present this first case. It's a 48-year-old woman. She's married with 2 children. She's a nurse and no family history of cancer. At the beginning of 2015, she began with pelvic discomfort and constipation. She saw her gynecologist for the first assessment, and the pelvic ultrasound showed an axial left mass of 14 centimeters with irregular vascularization and no ascites. An MRI of the abdomen and pelvis also showed a mass on the left side of the pelvis with 13 centimeters, irregular, with no lymph nodes enlargement, no ascites, and no signs of peritoneal carcinomatosis. Her labs were totally normal, with normal CA1 to 5, CEA, and germ cell markers. She was referred to our hospital for the laparotomy, and the findings was an ovarian mass with intact capsule, no carcinomatosis or other implants. She proceeded to a total abdominal hysterectomy and bilateral salpingo-oophorectomy, omentectomy, rundal biopsies, pelvic and para-aortic lymphadenectomy. The final diagnosis was a granulosa cell tumor, figure 1C, grade 3. Then she was referred to our team for the adjuvant treatment. We decided to give 4 cycles of cisplatin and etoposide. She is now at the 4th cycle of chemo with limited hematological toxicity. And we have some questions about the case. The first one is the role of lymphadenectomy in granulosa cell tumor. If it's really necessary to obtain endometrial samples in all granulosa tumors, and what are the data of the indication of adjuvant treatment in stage 1 disease?
Okay, thanks, Eduardo. Marcelo, do you want to talk about the first question? The question is the role of lymphadenectomy in this. This is a stage 1, just for Don's benefit, stage 1 granulosa cell tumor of the ovary grade 3. And the final question here is going to be about chemo, but we'll have a surgical question first about the role of lymphadenectomy.
So in general, I think that these tumors, because of their nature and the fact that many of them are confined to the ovary, we generally don't do a comprehensive lymph node dissection like you would for an epithelial ovarian cancer unless you have lymph nodes that appear involved and then it's part of the debulking surgery. So at least at MGH, we don't generally do a comprehensive staging unless there's a question about the frozen section as to what the histology is of the tumor. But if it's a granulosa cell tumor of the ovary, for example, if this patient had a hysterectomy or just a oophorectomy outside the institution and she came in, we wouldn't subject her to comprehensive staging if she had imaging that was reassuring. So I don't know, if, Tom, if you want to.
I agree.
So no comprehensive lymphadenectomy, but how about lymph node sampling?
We don't.
Not even that.
Yeah.
Okay, so no sampling, no lymphadenectomy is the answer at MGH.
What about, I don't know if Kathleen wants to comment about the...
I don't think Kathleen's there yet.
She is.
She is. Oh, great. Kathleen, hi.
She has an entourage.
I'm in Brazil, so I'm in Barretos with Georgia, one of the GYN oncologists who joins you regularly, and Melissa Lopez, who's from MD Anderson, who's here with us. But I would agree, we also do not do lymphadenectomy or lymph node sampling in these patients. There's a couple of nice retrospective studies. They're old, they're a little bit old now, but one was done at Memorial Sloan Kettering and one was done by, I think, Jubilee Brown at MD Anderson. And both of them showed that the probability of having lymph node metastases without evidence of other metastases was so low that really lymph node dissection is not warranted. So we also do not perform them in these patients.
And that's with you knowing that it's a stage 1C, Kathleen.
So we treat, I think that's the next question, but with stage 1, the only patients we do not give adjuvant treatment to are stage 1A patients. And that's a little bit of a misnomer because it's really a clinical stage 1A because we don't do lymph nodes. But if the mass is confined to the ovary, removed intact, and no other evidence of metastatic disease at surgical exploration and/or imaging, then we do not give adjuvant treatment, but everyone else gets adjuvant therapy.
That's great. Are there any other local surgical or radiation issues yet, Tom?
Well, Eduardo, I appreciate the second question, which I think is very astute, and I completely agree that every woman with a granulosa cell tumor should have endometrial sampling at some point, either a hysterectomy at the time of surgery or sampling ahead of time, or at least if she wants to preserve fertility, a D&C at the time of the surgery, since these tumors do produce a lot of estrogen, and it's not rare for there to be a concomitant endometrial malignancy or atypical hyperplasia with this presentation.
And now we get to the chemo. Thank you, Tom. We get to the chemo now. Tom, do you want to?
Well, I mean, I think Kathleen sort of summarized it. I think patients with advanced disease oftentimes will get adjuvant therapy. We don't have a lot of great data to say what is advanced disease. I think if it was stage 2 and higher, everyone would agree on chemotherapy there. Stage 1A, everyone would agree no chemotherapy there. Stages 1B and C, it's really up in the air what you do. There's not a great data set out there. I think if she didn't want chemotherapy and was committed to follow-up, then I think that would be acceptable. But I think most people would probably end up giving chemotherapy for this. You know, we extrapolate from male germ cell tumors, so the consideration will be EP with or without bleomycin. Bleomycin, etope, cisplatin, you can give 3 cycles. If you do EP, we generally give 4. Here at Mass General, we try to do BEP unless there's a contraindication.
Salvage is pretty good.
Salvage is because surgically, these people are often able to undergo a secondary surgery quite successfully, and then you can reserve your chemotherapy for later.
I have a question for, in terms of, so this patient, when she had her marker sent, Eduardo, did she have an inhibin B level sent with their initial markers?
Inhibin B, Eduardo.
No, unfortunately, we do not have inhibin B here.
Okay. So I think if her markers were negative, and it's just an interesting question as to how you're going to follow her, because these tumors have a propensity to recur later, 10, 20 years later. So one of the things that we always struggle with is in women that present with early stage disease who don't have a biomarker for their malignancy, is how do you do surveillance for them long term.
So what do you do?
And would you consider using estrogen in this woman who's had a BSO?
Just a BSO?
Well, no, she's had a TAH BSO, and so she's got no ovaries. She's 48.
Yeah.
It's not as good as inhibin B, but you could maybe consider using estradiol.
Yeah, estradiol as a marker. Yeah, I think that we struggle with these patients in our tumor board in terms of surveillance because I don't think that there are any standard surveillance modalities. But in general, I would say probably an estrogen level, like Tommy suggesting, would be a marker.
At baseline, as a biomarker.
Yeah, at a baseline, right, exactly.
And only if it's elevated would you use it for surveillance, or you use it anyway?
I think you probably use it anywhere, right? Because you'd expect it to go up if she develops a recurrence. And then I think imaging is always controversial in terms of what imaging modality to use and how often. I don't know if Don has.
No, I mean, I agree. I mean, it's sort of an individualized thing. Even in the United States, some people want to be imaged very frequently. Others are okay with close clinical examinations. I don't think it's unreasonable to do, every 6 months and then, for a certain amount of times, imaging with a CAT scan, and then go to annual imaging. But the concern is exactly what Marcella said. These patients tend to recur later. So maybe you should be scanning less frequently in the first 5 years and more frequently in the later years. I think, ultimately, if you do find relapse disease, it's oftentimes going to be intra-abdominal and surgically approachable. Kathleen, what do you guys do for surveillance?
We're all over the place. I think for the reasons you mentioned, there's no routine surveillance. We do follow them with inhibin levels. I just asked Georgia here at Barretos if they use inhibin levels, and she said no, they cost about $500. So a reality check for us. I have no idea how much they cost at MD Anderson, but it's like
probably $5,000.
Yeah.
MD Anderson.
So can I just ask, Kathleen and Marcella, all of you, with measuring estradiol after bilateral oophorectomy, are the assays sufficiently sensitive and adequate in the average hospital to do estradiol assessment in a patient who had bilateral oophorectomy? You're just looking for a spike? You're looking for a pathological spike in the level?
You're looking for a rise over,
A real rise, okay, all right. And so that would be the sort of, if you like, the poor man's version of inhibin. Right?
Exactly.
Right, you use estradiol and you use intermittent CAT scanning of the pelvis. There's no format for follow-up here that's agreed upon. Okay, thank you very much. Well, that was a great case. The second
Can we go back to the chemo? Can I just bring something up about the chemo? We actually tend to use Taxol and carboplatin for these tumors now. There's retrospective data from Dr. David Gershenson that it's equivalent to BAP or BEP. So there's an ongoing prospective study through the GOG comparing BAP to Taxol carbo. But just so you know, that's another option for these patients.
Yeah, I'd be kind of leery of that, I guess, because of the testicular cancer literature showing carbo is probably not as good as cisplatin, at least in those tumors. So, it's apples and oranges, but, I probably have only used carbotaxol in the relapse setting after EP. And, I think it is an effective regimen. If you're going for curative intent, I probably would stick with historical regimens, at least right now, off protocol.
And so the final question I have is there any role for giving the chemotherapy neoadjuvantly, or it's not been done?
It's never been an issue because we oftentimes will pick these up as isolated ovarian tumors. It's very rare to see an advanced intra-abdominal process for the granulosa.
So overall, the survival is good?
Yeah.
Okay. Yeah. All right. Well, thank you very much, Eduardo. Thank you. The second case, Aknar from Salvador. Aknar, are you ready?
We can't hear you, Aknar.
Aknar, can you turn your microphone on?
I'm going to let you handle that.
That's why I'm so glad you're here.
No, we still can't hear you, Aknar. Can you tell me what to do, Jessica?
Can you check the settings of your speakers? We heard you a moment ago. But if you click the gear wheel at the top of your screen, it's next to the red telephone. It should give you a drop-down menu to select your microphone. And can you select the appropriate microphone that you have?
No.
Not yet.
No, not yet.
We still can't hear you. Funny, we could hear her a little while ago.
Right.
Eduardo, if we can't get a live voice from Aknar, have you got the cases in front of you? Would you mind presenting the second case to the assembled group?
There's no problem. No problem. That's okay for me.
Okay. That's strange because we were connected a second ago.
Mm-hmm.
That's
Aknar, just look next to the telephone on the top. There's a wheel. Just push the wheel, and it'll drop down and let you choose one of the microphones, if a Jabra microphone or whatever you're using. She could phone, but we must have Eduardo just present the second case. Okay. While Aknar is trying.
We can't turn it on for remotely.
No, we can't. Eduardo, maybe you'd mind we'll share the slides, and if you wouldn't mind presenting the second case for Aknar.
That's okay.
Thank you.
Hello again.
Yeah.
I'm going to present the second case from Salvador, Brazil. It's a 57-year-old woman. She has 2 previous pregnancies. She's previous health, non-smoker, and a family history of thyroid cancer, a sister. In 2013, she detected a right ovarian cyst on the ultrasound, 12 centimeters, and the volume is 655 centimeters, I don't know how to say, 3. Cystic tumor with thick endometrious content. She was prescribed groseladine plus levonorgestrel, decreased the cyst in volume. An ultrasound that was made 5 months ago, she had a solid intracyst vegetation with vascularization on Doppler, deep endometriosis focus on the upper retrocervical region, 1.6 centimeters, and a CA125 at 35. She had no alterations on physical examination. She had a PS equal of 0, and pelvis MRI with a vaginal cyst with hematic and epiproteic content, no contrast uptake, uterine leiomyomas, deep heterouterine endometriosis with local adherence, cysts on both ovaries, that was suggested to be endometriotics, with hematic and epiproteic content, right and left intracystic vegetation on the right cyst with heterogeneous uptake of contrast. The thorax CT showed nodules in the lower lobe, left lower lobe, of 6 millimeters. She proceeded to a bilateral salpingo oophorectomy. The pathology showed a high-grade endometrioid adenocarcinoma with associated undifferentiated adenocarcinoma with high mitotic count, high-grade stromal sarcoma associated with chondromyxoid areas.
Can you hear me?
Yes, we can.
Okay. Sorry for.
Do I continue?
Well, Eduardo, maybe Eknar can continue. Do you have the right slide up, Eknar? You can see it.
Okay.
Thank you.
So it was the first surgery of it was a high-grade endometrial carcinoma with associated undifferentiated adenocarcinoma with nuclear atypia, high mitotic count. There was also a high-grade endometrial stromal sarcoma associated with chondromyxoid areas. There is a vascular invasion and focal, but the surface of the ovari was free, and there was a tumor necrosis of 30%. So it was stage 1A ovarian carcinosarcoma. It was performed an extensive immunohistochemistry that confirmed it was a mixed histological tumor. Next, please. Next. And so we decided to do a complete surgery with a second laparotomy with oncological intent. So it was performed the total hysterectomy. Because she has endometriosis, it was the uterus was fixed to the rectum, so it was performed a hexosigmoidectomy, pelvic lymphadenectomy, and the final pathology showed no residual disease. The cytology wash was negative. The next. So that's our question. After the first surgery, if you would recommend to do the cytoreduction procedure, and if you recommend adjuvant chemotherapy, if yes, which regimen?
So I just have a question, and it's primarily the intraoperative findings at the time of the second operation. Was it a cytoreductive surgery or was it a staging procedure? And why was the sigmoid removed? Trying to understand what was the distribution of disease, if any, at the time of the second surgery.
I didn't understand your question. What's your question?
Thank you again.
Yeah, because the staging, you defined the stage of the tumor as a stage 1A.
Yes.
But the second surgery she had, was the sigmoid resection done for endometriosis or was it done for malignancy?
We decided to perform for both because we didn't know if there is residual disease, because the first procedure was not intended to be oncological surgery. So we decided to perform a complete staging and do a cytoreduction to stage the patient. And as she has extensive endometriosis, we decided to also treat endometriosis, not to interfere with the follow-up of the patients. So we'll do both.
Thank you.
Okay. Yeah. Do you want to make some comments about this?
Okay, so the pathology was negative. So the pathology of the second procedure was completely negative for malignancy?
Yes. Yes.
Was there evidence of endometriosis?
No, it was endometriosis between the uterus and the rectum, but there is no carcinoma, no residual carcinoma. It was only endometriosis in that site.
Okay.
It was an atypical endometriosis.
Was she managed correctly from the beginning, or was something done incorrectly in the beginning? Not incorrectly, but in a...
Well, I mean, it's a little confusing. I'm not entirely clear why a 57-year-old woman with an abnormal ovarian cyst would get hormonal treatments with goserelin and norgestrel. So that's a little unusual.
I don't know. I didn't know why she did that. It was a gynecological who performed that, a general gynecologist.
Right. So there's not to belabor the obvious point, but I think there's a opportunity for quality improvement there. That I think with a symptomatic, even if it appears to be endometriosis, a symptomatic mass in a postmenopausal woman is an indication for surgery and not for conservative treatment. And obviously that could have prevented a lot of this. I do agree with you that once the findings of the first surgery were identified, there's no way to know, even if a biopsy shows endometriosis in your core biopsy in that mass between the rectum and the uterus, I think it still needs to be completely resected. I agree.
And not to belabor the point, but we know in 1927, Dr. Sampson was the first one to describe the association between endometriosis and ovarian cancer. And so I think that in a 57-year-old, even if the imaging is, remember that endometriosis is a histological diagnosis, but if the imaging was consistent with an endometriotic cyst, because of that association, although there's never been any causality established, we would, have offered her surgery before she was ever offered. I mean, I agree with Dawn and Tom that medical management of a cyst in a 57-year-old, something that big, I think she should have surgery up front. And I also agree with the staging surgery because you don't really know what's there, and it's going to guide I think, your therapy.
Sure.
So her ovarian, the capsule was intact on the ovary that had the cancer.
Yes.
Okay, and you found sarcoma as well as 2 different types of adenocarcinomatous patterns.
Yes. Yes.
Okay. Yeah, it kind of threw me because you say it's a high-grade endometrial stromal sarcoma, but that language would not apply, correct? Because this is not a uterine lesion.
It was, I don't know, I can see the slides, but it was a high-grade endometrial carcinoma plus a high-grade sarcoma.
It was a high-grade sarcoma. Okay. Okay. All right.
So she has a
Bad.
carcinosarcoma arising in
Carcinosarcoma.
I don't know if it's endometriosis because it was in the ovary. That's
Sorry,
But
Agnar?
it has endometrial
Sorry,
stroma.
just say that again, please, Agnar.
A high-grade carcinosarcoma of the ovary.
Of the ovary. Yeah,
With
okay.
both components of high grade.
I don't think I would consider this, and I think we're sort of debating this on it. I don't think I would consider this an endometriosis-associated cancer.
Well, so I think,
This is the
it's
question.
controversial because I think one of the issues, we've done a lot of work here at MGH looking at these tumors that arise in endometriosis, and one of the problems that we have in trying to establish the prevalence is that, and partly is that a lot of times these tumors completely erode through the endometriosis, or it's missed by pathology. So a lot of, so you have to be looking out for the endometriosis in the malignancy, specimen. And many a times, what you find is that the endometriosis is, sort of pushed out of the way by the tumor. So I still think that if you found endometriosis in the field, the way that, I mean, this is getting a little bit beyond maybe the scope of the conversation, but the way that pathologists make this diagnosis, they have to see a transition within the same slide between malignancy and endometriosis, and that can be missed. So I don't know that we know whether this is associated with endometriosis or not, but I almost think it's a
moot point.
It's a moot point, yeah.
But,
but
the fact of a mass in a 57-year-old woman dictates a pretty radical surgery up front, not just a biopsy.
At least removal of the
biopsy.
ovary at presentation.
We wouldn't have biopsy.
Okay.
This was a complex mass over 10 centimeters in size in a
In a
postmenopausal
57-year-old.
woman.
It's really too bad we don't have the gynecologist to refer the patient to you.
No,
Was this-
I guess, practically speaking, and this is the other issue that comes up with endometriosis-associated ovarian cancers, may not apply at all if we think it's a primary ovarian cancer, is the role of radiation therapy. Because oftentimes we will even entertain radiation therapy to the pelvis as a means to control cancers that arise out of endometriosis. If we thought this was a primary ovarian tumor, that discussion wouldn't be something that we would have. I mean, we'd still give chemo, but oftentimes our radiation oncologists are big about sort of treating a field. Kathleen, any thoughts on this?
Vocês entenderam a pergunta?
So we treat with chemo as well. We treat with Taxol and carboplatin, but Patty Eisel, one of our radiation oncologists, talks a lot about this, and we have definitely given radiation for the cancer-rising endometriosis, but it usually tends to be endometrioid and clear cell. I haven't actually seen this with the carcinosarcoma.
Right, that was my impression as well. I don't remember seeing sarcomatous elements in an endometriosis-associated tumor.
No.
Anyway.
There's one report in the Lancet. There's a study in the Lancet from about 5 years ago that looked at these endometriosis-associated cancers, and they found that most of the histology, as Kathleen just noted, is endometrioid and clear cell, but there was also an association with low-grade serous ovarian cancer, but none, I don't remember from that paper that there were any, and it's one of the largest series out there in carcinosarcoma. I don't remember any.
So just summarize the learning point from the very first presentation of what sort of went askew from the beginning,
Well,
and how seriously that was a problem.
So I think, I think in a 57-year-old with a mass that large, we would have offered her surgical resection of the ovary to make a histologic diagnosis because she does carry an increased risk of having that be malignant. So we would not have offered her hormonal therapy for that mass.
And from there, a lot of things potentially could have gone wrong or did go wrong. And she
had basically she got medical management for for malignancy.
you know what's fascinating is that ultrasound was in 2013, and she sat on a carcinosarcoma for 2 years, and there was no metastatic spread. I think that's fascinating.
Well, unless the pathology has been right. I mean, unless if you look again, a lot of the data on endometriosis-associated ovarian cancers are largely retrospective. All of them are. And the general theme is that these patients do better. For reasons that are unclear, if you correct for stage, the women that have, even the ones that have clear cell, when you compare them to the ones who have clear cell of the ovary not associated with endometriosis, they tend to do better. So I don't know if, it's hard to know because it is a little bit of a gap between her initial presentation and her surgery.
Yeah, so I would agree with Marcella, though. Postmenopausal women with a complicated cystic mass, you have to presume malignant, and you need to do surgical procedures on this patient. And we generally wouldn't biopsy; we would just go straight to sublingual oophorectomy. In terms of the second procedure, I think the only relevant data that I can think of is retrospective, and we did a study in Providence that asked whether or not you had to stage if you were going to give for these what were presumed to be early stage ovarian cancers. So what we did was we looked at our experience with early stage. Maybe it was a presumed cyst, and the benign gynecologist just did a BSO, and it ended up being malignancy. And it looked like as long as you were going to give chemotherapy, you may not need that second surgery. And it was a backwards way of sort of explaining 2 of the randomized trials in early ovarian cancer. But in general, we always default to surgical staging, not only to make sure that the disease is all out, but I think prognostically it's important to know what the stage is, because that's going to inform what you tell your patient. There's also no doubt, I think any of us would give chemotherapy in the adjuvant setting. This is a high-risk lesion. So yeah.
And what would you give her?
Well, we would give carboplatin and Taxol.
Yeah.
So it sounds like
smarter
nobody on either side of this discussion could be faulted for the management, but perhaps a discussion with a gynecologist is necessary on this case, Akmal. That's to me the real. Unfortunately, our third case. Sorry, I can't hear. It's an area.
Can I ask a question? Sure.
Go ahead.
If you carboplatin quickly, everyone cannot hear.
Everybody mute their microphones, please. That's much better. Thank you. Thank you very much. Okay. Sorry, Akna, ask your question.
you're going to do carboplatin and paclitaxel. Would you do every 3 weeks or weekly? And the second question, if she should use bevacizumab or not.
I think that's a nice question in terms of the sequence of therapy. There's as you're alluding to, there's certainly options for treatment. Most of those studies have looked at more advanced disease in stage 1A. Personally, I don't think I would not say it's not unreasonable to do weekly therapy using carboplatin every 3 weeks and weekly Taxol like the Japanese did and like we did in the GOG. I probably am leaning towards not giving bevacizumab at this point for early stage ovarian cancer. If you look at the study that was done with GOG 262, it looked like if you gave weekly Taxol and you gave the Avastin, there was really no difference in just giving weekly Taxol with carboplatin alone. But if you didn't give the Avastin, weekly Taxol was better than every 3 weeks. So if you want to sort of give her the benefit of the best, quote, best treatment around, I think and she was willing to accept weekly therapy, I would be fine with carbo weekly Taxol. Otherwise, every 21 day.
Okay, thank you. I just want to say that unfortunately, despite our testing with Guatemala, they haven't been able to join. So I'm going to have Rosanna Ruiz from Lima, Peru, just present the third case. So if everybody would just like to follow on the slides, Rosanna's going to present the third case. It's not her case, but she'll present it.
Okay, this case is about a 42-year-old woman with 6 pregnancies, 4 children and 2 abortions, non-smoker. She presents with a history of post-coital vaginal bleeding and discharge for the past 4 months. At the physical examination, a 4-centimeter exophytic tumor was found, also with left parametral invasion, but did not reach the pelvic wall. The CT scan showed no pelvic or periaortic adenopathy and no invasion to adjacent tissues. So a biopsy was performed, giving the diagnosis of a cervical invasive squamous carcinoma of grade 2 and stage 2B. In the second quarter of 2013, she had the initial treatment plan of giving concomitant chemoradiotherapy. However, as the average waiting time is prolonged, about 6 months because of the burden of the hospital, she was enrolled on a radiotherapy sparing clinical trial using neoadjuvant chemotherapy followed by radical hysterectomy. She was given cisplatin plus fluorouracil each 21 days per times 3. She achieved a partial response with a tumor going from 4 to 2 centimeters and with minimal parametral invasion. In the third quarter of 2013, she underwent a type 3 radical hysterectomy, and the final pathology was a residual tumor of 1.8 centimeters without lymphovascular invasion, less than 50% stromal invasion with clear margins, and lymph node involvement. In the right 9 lymph nodes, left 7 and 5 periaortic lymph nodes. She was followed up with pap smears and colposcopy every 3 months for the first year, and then every 6 months thereafter, and also with CT scans and chest X-rays. It's been 2 years now, and she's without evidence of disease. So the first question would be, what is the panel experience with neoadjuvant chemotherapy for cervical cancer?
Well, we don't really do it.
Is that just because we don't have the need to do it, or because?
Yeah, I mean the paradigms right now, you can cure most women with locally advanced cervical cancer with chemoradiation. And we generally will do definitive chemoradiation in this country. and try not to do a hysterectomy with advanced disease, because most often if you start with a hysterectomy, you will need to give some form of adjuvant therapy, which increases the toxicity of the therapy. So if we can treat with definitive chemorads and do it quickly, I noted here that they had a waiting time of 6 months, which was problematic, really. We can get people in and through within 8 to 12 weeks.
I've seen the declining mortality curves for cervix cancer in the United States. They're dramatic.
Yeah, we can't do trials in the United States.
But I was going to ask you, is part of what we discuss on all these tumor boards the fact that we simply don't see locally advanced cervix cancer anymore in the United States?
We'll still see it, but it's a rarer phenomenon, and it's probably going to be rarer even as vaccination rates for HPV increase.
Right. And so therefore the trials for neoadjuvant chemotherapy, for
they're all going on ex-US.
Ex-US,
yeah.
There's no real patient population for that, fortunately, in the United States.
Right? Is that correct?
That's right.
Yeah.
That's right.
Yeah.
So ironically, our Latin American colleagues may present to us lots of types of cases for which we have less experience than them now.
Right.
And so you want to take the initiative on some of these locally advanced or advanced cervix cancers in Latin America, because we simply don't have those cases sufficiently to do clinical trials in the United States any longer, which is a blessing, of course. But
and in fact, we should be presenting our cervical cancer patients.
Yeah, we should be asking. You see what Tom Randall says. We need advice from South America on how to manage cervix cancer now in its locally advanced form or metastatic form, because we simply have very little experience with it any longer in the United States, which is a blessing, actually.
So can I just ask a question? This clinical trial she was in, do we know? No one's from Guatemala on the call.
No. What's the question?
Well, it's a fairly, it's a very unique way to treat cervical cancer, to not give radiation therapy at all.
Okay.
Is unique. And to do most of the neoadjuvant, and maybe folks here can correct me, most of the neoadjuvant experiences in cervical cancer start with chemotherapy, get people to surgery, and then they do definitive treatment. Oftentimes it is chemoradiation on the back end.
After the neoadjuvant.
Right. So it's not, I haven't yet to see a trial where radiation therapy is not included in the curative paradigm. So this is why I'm asking about this trial, which I think is very interesting.
We can sometimes do this in my country on an institutional way, and it is restricted to patients with stage 1 cervical cancer, not for stage 2. And however, if you reach a pathological response without any residual tumor, without lymph node involvement and no parametrial residual disease, you could consider not giving chemoradiation for definitive treatment. However, in this case, this patient presents with residual disease, for sure she will have received chemoradiation on top of the surgery.
So it's an interesting thing. I'm not sure this trial, as stated in one line, would pass an ethical bar.
Okay.
In this
because of the absence of radiation.
Yeah. Kathleen, any thoughts?
Yeah, I actually have a lot of thoughts.
Maybe
well,
you're three.
I just think one thing to remember is that the countries that have the highest incidence of advanced stage cervical cancer either don't have a radiation machine or don't have a working radiation machine or safe radiotherapy, certainly in the community, outside the capital city. So I think that this is a really, really important concept of neoadjuvant chemo for cervical cancer. We do not do it at MD Anderson because our radiation oncologists would, it just won't happen because we've got such great radiation therapy. But I think just something to remember. I think Aldo, I don't know if your colleague from Peru is from INAN working with Aldo Lopez, but he's actually currently in Houston, and he's writing up with us his retrospective experience of using neoadjuvant chemo because there was no access to timely radiation therapy for some of those patients. And he's in Lima where they have radiation therapy, but he said for a lot of the country, it's a big challenge. So I think it's a very, very important concept that we need to study further and to really work with our colleagues in Latin America to
And
do those
Kathy,
studies.
can I just add to that point? We've been working with the breast group at INAN and Rosanna's boss, Henry Gomez, and they are just at the moment introducing a peripheral chemo clinic. So when breast cancer patients require chemo, many of them cannot even come for their chemotherapy to Lima. And so some patients come and sleep on the street outside the hospital in order to get their 6-month course of chemotherapy. So it's very impractical. And they've set up, guided by the Canadians who have a geographic need for peripheral clinics, they have set up a peripheral clinic for adjuvant, for chemotherapy to be given. They give the first course in Lima, and then they return the patient to their home in the rural area, and they have chemotherapy being delivered in that. So that even states more evidently, I think, Kathleen, that if this were pioneered and proved to be a reasonable approach, you're quite right that in Lima, in Peru, there are very few radiation machines outside of Lima, if any, according to my memory. And many countries, there's very scarcity of radiation machine or technologists or whatever appropriate for treatment in the peripheral area.
Well, then I think to actually carry on to what Kathleen just said, it would be really interesting if we could report with Latin American data what is the prognostic significance of pathologic CR in cervical cancer. Is it mirroring breast cancer, where neoadjuvant therapy is all delivered first, surgery is done, and then often there is no adjuvant chemotherapy? So in my mind, the question that is yet to be answered is, does pathologic CR, is it prognostic, long-term for survival? And if there is an experience of that, that could be multi-institutional, that would be a huge contribution. And I think if we had that data, we could design a study in the US of neoadjuvant chemotherapy.
And perhaps that's what this patient is on a trial of, that question.
Yeah.
We haven't got the doctor presenting the case, but that could be the case.
Yeah, unfortunately, ideally, right, you'd want to randomly assign patients to neoadjuvant chemo with adjuvant RT versus without, and just treat everybody that way, regardless of the pathologic response, and you get a clean answer. But being what it is, you have, basically phase 2 data, and you can report that and sort of subdivide your population.
And I just want to add, we could learn from the Latin Americans. I mean, a big problem in the U.S. is women who present with advanced stage cervical cancer who still want future fertility. And if we radiate them, then they lose that option. So there's some small series on neoadjuvant chemo for fertility-sparing reasons in this country, and certainly in Europe and in Canada. So I think it's a very important question that we have ignored at the U.S. cancer centers because we have such strong radiation therapy. But I think it's a really important worldwide question that would also apply to our patients here in the U.S.
It would be good to get that preliminary data so you could build a foundation, because I agree there is going to be quite significant pushback in not using radiation therapy in cervical cancer.
Do you want to comment, Tom?
Oh no, I mean, as the group knows, we've talked about this a couple times before. I think gathering the information from Latin America is going to be very important. I don't think we're ever going to be at a point where between the scarcity of patients with this presentation and the clinical situation on the ground, we'll never do that clinical trial in North America. And so it's going to need to be done in Latin America. Other low and middle income countries have other challenges that Latin America doesn't face. And so I think this clinical question has to be addressed in Latin America.
Yeah.
That's great, yeah.
I agree.
Kathleen, did you finish all the points that you said you had to make?
For now, yeah.
Okay. Any other comments on this case, the third case that we just heard about? The one and only case. The first two cases, unlike our previous tumor boards, which were confined to cervix cancer in the past, as you know, we expanded to all gynecologic tumors. And the first two cases were very interesting and presented ovarian cancer cases. So I think that if there are any other comments or discussion points, or research points, or paper points, or retrospective review points.
I think you should try to lead that effort to stratify by response with your network, it would be a really important.
But I slightly misunderstood your comments. I think I know you were correct, but I just want to drill down on it. You say the correct clinical trial would not be just treating patients to complete pathological remission and then observing them like a one-arm phase 2 trial.
Right, you wouldn't know. So if you wouldn't want to stratify people because you're assuming pathologic CR predicts prolonged overall. That's an assumption right now in cervical cancer. So you include everybody from the start.
What kind of relapse pattern would you expect in the time frame? How long would this trial have to be?
Well, I think local recurrences from cervical cancer usually within the first 5, certainly.
Certainly, and 80% of them are in the first 3.
First 3, yeah. So
3 years.
You get some intermediate data at 3 years.
You could get it at 3 years.
So this is a clinical trial for all of you in Latin America to consider. Just randomizing to neoadjuvant chemo alone.
But even if we could, even at this point, as Don's saying, if we could just have a registry, if we could pool the data.
I mean, if you know there are certain
between Neoclassicus and Barretos and other centers.
Well, Eduardo's coming to work with us. Eduardo Paulino, just wave again. Eduardo.
There we go. There's our.
He's coming to work with us starting in June or July. So. It is going to be working with you guys and us, so we can pool our resources and maybe try and see if a retrospective series could be collected.
Exactly.
So that's very great. Thank you very much. Any other comments? Brittany, you've been very quiet. Do you have any comments?
No, I don't have anything really to add. I would, just kind of stress, as others did, kind of the, and we need to assess what the issues are with the lack of capacity for radiation in Latin America. Is it an educational issue? Is it lack of equipment? Is it a cost issue? Because brachytherapy is, in my opinion, relatively inexpensive. It's old technology. So I think that we need to consider that in this context.
So there's a whole field, as you know, as everybody knows, there's a whole field of designing clinical treatments, abbreviated clinical treatments that are pragmatic, fewer weeks, fewer fractions, fewer this, fewer that.
Mm-hmm.
Those kinds of menus of choices are just pragmatic for South America. They just can't handle the volume and the geographic distribution of the patients. And Brittany, does this tie in at all to the very nice HPV paper you've just published and led for all of us as a group?
So it does a little bit. In that paper, we really stress the importance of HPV vaccination and, good screening programs to prevent cervical cancer. And I think that that's probably the best way that Latin America can invest their resources to reduce the burden of cervical cancer in the region. We didn't discuss in the paper about treatment of cervical cancer and management.
And Brittany, I might just have ACNAR add to that. ACNAR, I think I've understood you saying that Bahia, the state of Bahia in Brazil, has 13.5 million people and a very high cervix cancer rate, and all the patients in the entire state have to come to Salvador for treatment. Is that correct? Would you just describe what goes on in Bahia and Salvador for us, please?
We have few radiotherapy services in Bahia. 80% of the cervical cancers in Bahia come to Salvador to be treated. There's also, I think, 2 machines in the rural area because it's a huge state, but 80% of the cases are here in Salvador.
So it's got 13.5 million people in the state and 2 machines outside of Salvador. That's pretty poor radiation. So most of the patients come to Salvador for radiation and for other treatment. Okay, thank you very much. Well, anyway, I think these cases really highlighted some of the important differences between Latin America and the United States, and were very interesting and challenging cases. So thank you very much, everybody. And we will please remember to take some pictures for us. We love seeing pictures of you, okay? Thank you very much, everybody.
Thank you.
Okay, bye now. Thank you very much. Okay, we can